guess we'll get started, everyone. Thanks for joining this session. It makes me feel very excited that you took the time out to come. Before we get started, I just want to acknowledge that, again, the land that we are presenting on today is the unceded territory of the Musqueam, Squamish, and Tsleil-Waututh peoples. I'm Julia Burt. I am the Public Engagement Lead with Health Data Research Network Canada. Going forward, we will call it HDRN Canada. And I'll let my colleagues briefly introduce themselves.
Good morning, everyone. My name is Bill Pratt, and I'm a member of the Public Advisory Committee for HDRN.
Good morning, everyone. My name is Jannath Naveed. I'm the Public Engagement Research Assistant with HDRN Canada.
Thanks to both of you. So before we get started, just to let you know that we are hoping to use Slido today to have a bit more of an audience interaction throughout the session. So if you get a chance, you can go on Slido now on your phones, or if you're online, you can go on your computer. If it doesn't work, it's okay, we'll improvise. It's just a way to kind of get some more discussion going. What we want to talk about today is a little bit about what Health Data Research Network Canada does, who we are, what our mandate is, but then really focus on how we engage with members of the public. And we will highlight some key projects and initiatives that we have undertaken or plan to undertake in the area of patient and public engagement. We'll talk about what we've learned, some of the key themes that have come up over the many discussions and dialogue we've had with members of the public in the health data space. And as I said, we hope to have a conversation today with you to understand what you feel about the use of health data and data-intensive health research.
Can you give us that Slido number again?
Yes.
306.
I'll put it up again once we get to the questions, so you'll have another chance, but I'll give you a second. Okay. So I like to start with a bit of a definition of health data because we'll be saying that term quite a lot, and people understand the term differently. But when we say health data, what we really mean are two things. So one is health-related data, so information about the health services that people receive. So this is type of information as you go through the healthcare system, you go to the emergency room, you go to see your family doctor, you get a prescription. All of that data is collected automatically as you just routinely go through the healthcare system. Oftentimes this data is identifiable, so it contains things like your name, your address, your personal health number, and all of this information is really important for providing continuity of care and good health care. I think people now are increasingly understanding and recognizing the value of health data for their own benefit, for being more informed in their own health care. But on a bigger picture, we know that health data can be important for things like research, and we'll get into that. But we can't forget about other types of health data. So many of you probably heard of the social determinants of health. So data that aren't necessarily collected directly in the healthcare system, but they are a broader range of social, economic, cultural factors that determine individual and population level health. So things like education, socioeconomic status, language, immigration status. And oftentimes we can link these two types of data, so health and health-related data, to better understand this complex thing that we call health and well-being. So when we say health data today, that's really what we're referring to, all of these different types of information that we're getting. So health data are powerful. And as I mentioned, people are starting to understand that. But data is very important in the broader sense as well. So researchers want to use and access it to better understand disease, treatment, well-being, how the healthcare system is functioning. The issue is in Canada, healthcare, as we probably all know, is delivered in single provinces and single territories. All healthcare systems function a little bit differently. That means that this data that's generated through your interactions with the healthcare system are often generated differently. They're maybe called something different. They're collected in a different way. So this makes it quite difficult to learn. So the health research that's happening in the country is often happening in individual provinces and territories. So it's hard to compare what's happening in one province and territory to another. This is where HDRN Canada comes in. So we are a pan-Canadian network of organizations that hold health data, and our goal really is to help researchers do more and better multi-jurisdictional research, so research that's using data from multiple provinces and territories. And this is important because, as I said, when researchers have access to health data from multiple provinces and territories, it's much easier to conduct research on things that are really important to all of us, like wait times, chronic disease, mental health. We are made up of a number of different national and provincial territorial organizations. There's just a couple up there on the slide. That's by no means all of them, but we are made up of SPORE support units, some other data institutes like Pop Data BC, some of you may be familiar with, as well as some more national organizations like Statistics Canada. We are supported from funding from the Strategy for Patient-Oriented Research, or SPORE. I think all of you are probably familiar with SPORE, as this is we're at a conference all about SPORE. But if not, this is an initiative from the Canadian Institutes of Health Research that's really focused on transforming patients and families from passive recipients of healthcare into active, proactive partners who really shape the health research landscape. I do like to make a couple of important points. HDRN Canada itself does not hold data, or we do not conduct research projects. It's our member organizations that are the ones that collect and hold the data, and then it's the researchers that access this data through us. So we are kind of like the facilitator or the conduit to this health data. And the other thing is, I mentioned that a lot of this health data is identifiable, but when researchers access this type of data, all of that identifying information is removed, so it is de-identified. I was glad that Dr. Amy Lang talked a bit about this today, but you've probably noticed that we don't use the term patient engagement. We use the term public and public engagement. But public or patient engagement is very important to us because we are funded by the Strategy for Patient-Oriented Research. But what we recognize is that the health data that HDRN member organizations collect extends beyond that of patients that are interacting with the healthcare system and involves all these various other public stakeholders. I've been myself in many conversations where people are debating the correct term to use or what they identify as. Some people do identify as partners, others identify as patients or people with lived experience. So we won't get into that here today, but we are using the term public engagement to encompass all of this type of engagement with health research. But as an initiative of the Strategy for Patient-Oriented Research, we want to make sure that our engagement is continuous, substantial, and meaningful, and that language is directly from the strategy and the public or patient engagement framework. So how do we do this? Well, we need a plan. This is quite a high-level overview of HDRN Canada's public engagement plan, and we're not going to go into detail about all of this today, but we will focus on a couple of the key streams and initiatives that we see here. But we know there's a lot of good work that's already ongoing in the Strategy for Patient-Oriented Research, and we didn't want to duplicate that. We really wanted to complement what was already going on. So to kind of come up with the work stream for this plan, we surveyed a number of member organizations who are part of HDRN Canada, as well as other SPORE entities, and those responses really formed the basis for what you see here on the screen. So the arrows there, we're going to talk a little bit about the Public Advisory Council of HDRN Canada, which is a very important way in which we engage with the public. We'll highlight a couple of projects and initiatives that we've undertaken or plan to undertake soon in the area of health data and public engagement, and then we'll talk a bit about our annual public forum. I say annual, we had our first one last year, we're planning our next one now, and it was quite an exciting event. And of course, all of our public engagement initiatives and efforts are informed by principles of inclusion, diversity, equity, and accessibility. With that, I'm going to pass it off to our wonderful Public Advisory Council member, Bill.
Thank you, Julie. Good morning again, everyone. My name is Bill Pratt, and I am, as Julie said, a member of the Public Advisory Committee. And really, that's the essence of what the Public Advisory Committee is, or the PAC, as we refer to ourselves, which is provide guidance from public perspectives to HDRN Canada about its priorities, development, and operations. So what does that mean? What does that look like? Well, we talk about things, and we try to give advice or guidance from our perspective as members of the public about how best to communicate with the public, because the public is large. There's a number of different ways to communicate, and particularly when you're communicating about something that can be very personal, can also be very explosive, if you will, health data, as well as can be very confusing. So we provide some guidance about how to communicate with the public. We help to identify medium, short-term, and long-term goals. We're there to provide some insights about what's important the public. And, when we talk about, who this Public Advisory Committee is, how we're made up, we have a reasonable cross-section of the country, and so when we share some ideas about important issues, that will inform HDR Canada as it moves forward with its objectives. And identifying, discussing new types of data that are out there, because as we all probably see, each of you in your worlds that you travel, there's all kinds of data that's popping up that's considered new and coming out of nowhere, so to speak, and then so we try to identify and discuss those items. So what does that look like? These are some of the members. There are 12 to 15 of us from across the country, and there's a whole variety of factors in terms of trying to ensure that we are a reasonable cross-section of this country. And what's important to note is that all of us, we are what you would consider, we are not health data research professionals. We are not in that field. In fact, one of the qualifications to be on the Public Advisory Committee is that we are not, I'm going to use the term fluent, because that's my word, that's maybe not HDR, but we are not experienced health data professionals. In fact, it's one of the few things, well, it might be the only thing that I'm attached to in my life where the aim is to be average. The difference is we may be average in our knowledge of health data. It's excellence that we're trying to perform as our commitment to HDR Canada. And I think it's important to understand, when we say average, because that's what helps us, because if we were all knowledgeable about health data, well, we wouldn't be much of a public advisory group then, would we? We'd be kind of like from the inside, and so that's the advantage of having not a lot of us. That's our website if you want to check us out. Now, before you get upset and say, I can't read that, that's okay. The next slide is going to go into a little more detail, and we'll zoom in a bit. This is the result. So the public advisory, oh, by the way, the PAC it started in 2019. So we're about 4 years old, so reasonably new in the journey to where we're headed. This came about, the PAC advised HDRN Canada and said, you know what, it might be interesting to understand what kind of health data is available across all jurisdictions in Canada. And so HDR can, because that could provide a lot of conversation about, what is health data, what's available, what are the disparities, the differences across the country. So let's zoom in. Here's an example. So across the top, you see the different jurisdictions in Canada. Down the left-hand side are some different types of public health data. The first one there is hospitalization data. If the square is black, that means that about 95% or more of the population, that data is available for researchers. If it's blank, it means there's no data available at this point in time. Now the next one says home care services data. So now you see there's a difference across this country, and I think Julia had indicated that on one of our initial slides about these differences across the Canada, and this is part of the country we live in. So some of the provinces have some home care services data, some don't, and you'll see over here, Newfoundland has a plan. So this grid on all those the rows that were there are different indicators that, and some will have a plan, some have nothing, and some have full data. As with a lot of data sometimes, it tends to raise more questions than answers. And that's okay. This is a great starting point, this grid. It helps people in the public try to understand what's happening. So within the PAC, we have two interest groups, and these interest groups support HDRN Canada and its work. Those two interest groups are IDEA and Communications. IDEA is inclusion, diversity, equity, and accessibility. Terms probably very familiar to everyone in this room. We help in terms of, we use this principle when we're recruiting for PAC. We look at how, again, when I talked about, with this cross-section of Canada, how can we ensure that we have IDEA principles at play? There's IDEA training for PAC members, so that as members of the public, we want to make sure that we understand the concepts of IDEA, so that when we're working with HDR Canada and looking at different issues, that we are very cognizant and familiar and following principles of IDEA, as well as then we serve as a link between HDR Canada IDEA team, who has their own team that's doing this, and the PAC itself. And of course, under communications, we're talking about how can we best communicate with the public. I'm just going to back up a second. So on that, we talk about plain language. Plain language is, we hear a lot about, and it's so important on an issue of data, because it is a complicated issue. It's complex. There's multiple players. We heard this morning, there's so many people involved in things. And a great example I use, it's a little facetious. If I was to yell the word, okay, I'm pretending, okay, this is not for real. If I was yelling the word fire, for the most part, I think we'd all probably understand. I'd probably have some animation in my face, and we'd probably understand something's going on. I probably need to figure out how to get out. If I came up here and said, excuse me, everyone, in the northwest quadrant of this building located at 1057 West Hastings Street, there seems to be a chemical combustion taking place. It seems to be some imminent danger possibly to those in surrounding area of various ethnicities and ages. Well, it's not going to work, right? So plain language is possible. We know we can do it as communities. We know we have plain language when we want to use it. So this is where we've spent, I don't say we spent a lot of time, but we certainly tried to contribute our best to making sure that the information around health data, because it is so personal and can be confusing, that it is easy for all of us to understand. We talked about the data grid, and of course there's the HDRN Canada website that we provide some commentary on how is this aligning with how do we best communicate with the public and issues that are important. When we get together, we do talk about different issues. We're not going to describe all these here, but these are some of the things we've talked about, whether it's Indigenous data sovereignty or private sector access to health data. We will talk about that as a pack, ask a lot of questions. That commentary then feeds into the HDRN Canada ecosystem for HDRN Canada then to continue on its work on these important topics. And with that, I will say thank you, and I'm going to turn it back to Julia.
Thank you, Bill. That was an excellent summary. We could have spent a lot more time talking about the PAC, but it was an excellent little sneak peek into what some of the exciting things that the PAC are doing. But we'll switch gears a little bit and talk about what I think was quite an exciting project. Maybe I'm biased, but this project was called the Social License for Uses of Health Data Project. And it's a bit of a mouthful, but I'll explain. In this project, we engaged with over 30 experienced patient and public advisors to better understand how they felt about health data, what they felt were acceptable uses, and maybe uses that weren't so acceptable in their perspective. The project was funded by the Public Health Agency of Canada to inform the Pan-Canadian Health Data Strategy. Some of you may be familiar with that strategy. But what we already knew going into this project is that most people feel that health data should be used. It's an asset, and it should be used for public benefit, but oftentimes the support that members of the public have is conditional. So most people that feel that certain conditions need to be in place, certain requirements must be met before they consider uses and users of health data to be acceptable. So these conditions or requirements might be related to things like privacy, equity, commercial organization use, all those sorts of things. So I also think it's important to understand this term social license and health data social license. The term social license, I believe, was first used in the mining industry. So a mining company would go into a community and start to mine, and does it have the support of members of the public or the people who are living in that community? So something can be legally allowed and not within social license. So there's a difference there. But the term is increasingly being used to describe which health data-related activities, or just generally which data-related activities have the support of members of the public and under what conditions. So when we say that a health data use is within a social license, we mean that it's a use or a user of health data that has public support, ideally. I hope that makes sense. So our methods really focused on inclusive public engagement. I say participants there on the slide, but in quotes because they were not participants. They were true contributors to the project, but we just use the term participants for simplicity. The end of the project coalesced into a report, a public report that's on the HDRN website. And the report contains their perspectives, not the perspectives of the project team or the researchers. A lot of previous work in this area focused on just asking people how they felt about different uses and users of health data. So we wanted to approach it in a little bit of a different way. We wanted to see if we could get this group of diverse people to come to consensus, so agree on two main things. One being uses and users of health data that they felt were within social license or acceptable, and uses and users of health data that they felt were not within social license or not acceptable according to them. And the second thing that we were hoping the group could come to consensus on was requirements, conditions, safeguards that they felt should be in place for health data use and users to be acceptable. I also like to acknowledge that we used inclusive design for this work. And again, I like to acknowledge the work of Yuta Trevorianis, who is the head of the Inclusive Design Research Institute at OCAD University. And using inclusive design, we wanted to highlight not only majority views, but also minority views that were present in this group of people. So views or perspectives that maybe were only felt by one or two people. And we did this because we know that people who hold minority views are less likely to be served by the status quo, but they are often the people that can inform us best on products, policies, procedures that work for everyone, not just the majority of the population. And I also like to note that even one or two people in our group of 30 plus would, of course, probably represent thousands of people across the country. So this is where we'll have hopefully a little bit of fun if this works as we have planned. Before I tell you what we found in our project, I thought it would be fun to see if we could kind of replicate something similar to what we did in this project to see the results and see if they're similar, see if they're different. So if we go, I'll give you a chance to put that in. And I'm hoping that we can start that. Otherwise, we might have to switch it to the other screen.
Did you go back to the code number?
Yes. So there's a.
Can I pick more than one?
Yes, so you can pick more than one. And I'll say the question is, and there should be more, I think, if you, yeah, I think it must scroll down. But from your perspective, what uses and users of health data are within social license? Now, I know when I say within social license, I mean socially acceptable to you. I know there are nuances. So many of you probably think that some of these uses and users of health data are acceptable as long as there are certain conditions in place, certain requirements that are met. We'll get into that in a minute, but this is just thinking about it, top of your head, what do you think? Is there any way to scroll down? Because I know there were more like options. Oh yeah, I see it. I see there's a little, if you just like scroll down maybe. Yeah, because I want to see some of those ones at the bottom there. I'll just give it another minute, and you can choose more than one. I don't see the numbers changing too much now, so that's the top, is it? I see. So we see a lot of support for data use by governments, policymakers, to understand disease and well-being, university-based researchers, healthcare facilities, health systems administrators, to drive health innovation and technology, healthcare providers, and then if we go down, I see a lot less support for pharmaceutical companies, commercial organizations, insurance companies, the use of identifiable health data, and for-profit. And again, this is, spoiler, this is very similar to what we found in our project. So I'll actually, if we can switch back to the slides, and I'll show you exactly what we found, but you'll see a lot of synergies there. So, as I said, we were hoping to help the group come to consensus. And these were the only 3 uses and users of health data that our group could come to consensus on. There were many others that were discussed that a lot of people felt were acceptable, but we couldn't get full consensus with everyone in the room. So our group agreed that it is within social license, or is it acceptable for health data to be used by healthcare practitioners to improve healthcare services, by governments, healthcare facilities, or health systems administrators to improve the healthcare system, and by university-based researchers to better understand the drivers of disease and well-being. They have felt that it was not within social license for health data to be used by someone or some organization to sell or resell someone else's identified health data, and for health data to be used in a way that has no patient and public or societal benefit. So you'll see that there's some there that weren't on this slide. For example, I think, something that came up today in the room was the use of data from commercial organizations, whether that be pharmaceutical companies or insurance. There's a wide variety of commercial organizations. That was one that was very divided. Some people felt like, yes, they should, as long as there are certain safeguards in place. Some people felt that absolutely doesn't matter what kind of commercial organization you are, you have, all you care about is profit. So there was a lot, they were much more divisive. So we couldn't come to consensus on those things. So again, we can go back to Slido, but this was, I mentioned nuances. So many of you probably feel that there are certain uses and users that you feel are acceptable, but as long as there are certain requirements or safeguards that are in place. You know, for example, I've just provided some example kind of categories there, but you know, you may feel that you support use of health data by commercial organizations as long as they don't sell your data or as long as they don't use it for marketing purposes. So that would be a requirement or a safeguard or a condition. When we did this project, to help people kind of think about this, we presented different requirements that already were present in the literature on this topic, and we categorized them into these 7 categories. So you can see them there. So I just gave an example of something about commercial organizations, but it could be, you know, another example could be, you know, I agree that the use about or from data from indigenous communities is acceptable as long as the principles of indigenous data sovereignty are in place. So that's another example of a requirement. I won't give you any more hints, but if we go to the Slido for this one, and I'm hoping this will show a word cloud, because this is how we presented it in our project. And I think I gave a bit of a word limit, but not too much. So just type as much as you want. It should be okay. I think things are still coming in. This is really interesting because just on first glance, I see some similarities to what we found, but also some differences. And I mean, that's completely understandable. We're engaging with a completely different group of people, and this is kind of the goal of this as well. We really wanted to continue this work and see how we could hear from other people with different perspectives. Obviously, we see privacy is a big one, and I think we all can agree that privacy is extremely important when we're dealing with the use of health data. It's a sensitive subject. Transparency, I will say that is one, and I'll show you our word cloud that we produced, and you'll see that transparency and themes related to transparency really showed up in our project as well. And equity, that also, again, is a common theme, and I think one that's extremely important. I'm wondering if this saves. I'd love to keep this. Kate, can you take a picture of it? It probably saves in Slido, but this is really interesting. If we could go back to, I hope everyone's done. Can you go back? Thank you. Thank you, Kate. Here was the word cloud that we produced out this project. Of course, you see health data. We didn't kind of filter out health data, so that came up in the middle, but that's just because that's the nature of the project. Transparency was a big one, and themes related to that, so trust, confidentiality, benefits. You see access came up. So I would say this was there's some differences there for sure, and then that is obviously going to happen, but I will say transparency, plain language, trust, those are themes that we keep hearing over and over and over again. The next project I will briefly talk about, not in as much detail because it hasn't been complete yet, but again, it's a theme that's coming up, and I think it's one that's quite important to many people. But it's called the Plain Language About Data Project. And Bill really touched on this quite well, but the basis of this project is that most people care about how their data are being used. But the issue is it's often very difficult to understand how your data are being used and who's using it. And this is not necessarily limited to health data. It could be any type of data. So you're going in online and you're buying something and you're entering your personal information. You often will get that big privacy policy that's spit out to you that no one reads. It's pages and pages, and it's full of jargon, and no one really knows what's going on. But you just hope that people aren't going to do anything nefarious with your data. We believe that organizations need to be transparent in their communications about data use by presenting plain language communications that are tailored to individual needs and perspectives. And I really like this quote here. You can't have trust without transparency, and you can't have transparency without plain language. And again, we're seeing some of those themes that we just came up in that previous Slido question. So again, this project really focuses on inclusive public engagement, and the plan is to have 2 stages. The objective of the project is really to better understand what people want to know about how their health data are being used. It's not to discuss what data use practices are good or not, or what they think, that what they support or not. It's just what do they want to know about how their health data are being used. And as I said, the plan is to do the project in 2 stages. The first will be virtual generative dialogues. We'll bring people together to have discussions about what they feel, what they want to know about how their data are being used. The second process, and I think this is really interesting, it'll involve a larger number of people. And what we're going to do is get them to create what we're calling their own personal data notices. So what they would want to see spit out when they are giving someone their data. So an example of a personal data notice written in plain language could be who's using your data, what's it being used for, how long they're going to keep it, are they going to sell it, will they sell it to a third party? So many different questions that people probably want to know. So how can we come up with a standard template or a couple of different templates that organizations can actually use in practice when they are communicating to the public about how data are being used? And I also said I would talk a little bit about our first public forum that we held this year, April 2023 in Winnipeg. And this forum really came out of, it was part of our public engagement plan. One of our work streams is knowledge sharing across patient and public community groups. So what we wanted to do is come up with a way that we could really have dialogue with members of the public and other stakeholders in this space, not just a one-way communication, doing a publication or an article, or we wanted to have that 2-way communication. So that the event was called Health Data for All of Us, Sharing Ideas and Priorities, and it was hosted in Winnipeg, as I said, in person and online. The event was planned by HDRN Canada's Public Engagement Working Group, as well as members of the Public Advisory Council. And as I said, we were hoping, and I think it was, an opportunity for researchers, members of the public, patients, community groups, and other stakeholders to share their thoughts and concerns about health data in Canada should or shouldn't be used. And as always, the event was planned and informed by best practices in IDEA. And I didn't put the entire agenda up here, but I just wanted to share some of what was discussed. So we talked about the importance of public involvement and engagement in data-intensive health research. We talked about the Canadian health data ecosystem, health equality, equity and justice. We had very interesting patient and public priorities for data-intensive health research facilitated dialogue session, and I'm hoping to replicate that a little bit here today in a minute. We'll see if it works. And we had a really interesting as well panel session called Making Health Data an Ally for All of Us. And this was bringing together 3 people who were bringing quite different perspectives on health data and storytelling in health data. Specifically perspectives of the Indigenous communities, the rare disease community, and refugee individuals. So that was a really interesting panel. And I'll note that the majority of these sessions are online on the HDRN Canada YouTube. So more Slido fun. As I mentioned, we had a facilitated dialogue session, and the session was guided by 3 questions focused on issues around health data use and data-intensive health research. And the first question, so if we switch back to Slido, that we asked the audience at this forum was, what do you think are the two most important problems that data-intensive research should focus on? And I didn't give you a big word limit, but I think you should have enough room. And I know this is a big question that we're never going to be able to get into today, but it's a start. Again, we're seeing equity as an important theme. I like that one. Time to access data is insane. Yeah. And access in general is a big one. I'll give it another 30 seconds. Again, that's a theme of, yeah, timely data, time. That's a big one. I see some ideas about big data, AI. And I will say that all of these themes that we're seeing here are ones that I would say, would Bill agree, that are being brought up by our Public Advisory Council as well. Yeah. That's probably good. I don't want to go over time, so maybe we could switch back to the slide, and I'll show you what came up in our session. And here we are. Yes. So I saw a lot of similarities. So equity and access were the two biggest ones that I think came up here today. Also came up in the forum. We did get a chance to talk about some of these ideas more. I don't think we'll have a chance to do that today, maybe at the end. But I do know that some people had not issues, but obviously these types of word clouds, they're a little bit crude, right? They're not so accurate. So a lot of people could have said access, but they meant different things. Some people mean access to data. Some people mean access to healthcare. So that's why, these word clouds they're not what we're going to hang our hats on, but they're just an interesting way to generate some discussion. And then we'll go back to Slido, but I'll just show you the question is, what do you think are the two biggest barriers to gaining strong public support for the collection and use of administrative health data? So if we can go back to Slido. Trust, trust, trust. Yep, and I can just tell you that was exactly what came out in our discussion at the event as well. Fear is a big one. In the panel discussion we had on making health data an ally for all of us, I believe it was one of our Public Advisory Council members who was speaking on behalf of the refugee communities, who said a lot of people who are coming to Canada have had not a very good experience with the healthcare system. They haven't been treated well by it. So they're not really looking to share any more information than they need to, or they're actually going to be withholding information. So that fear is a big one. Fear of misuse, I see it there as well. Yeah, data breaches and bad reputations. I mean, I would say not even just private organizations in the private sector sometimes have bad reputations. Even governments and other more public bodies that we would normally maybe trust more, sometimes they don't have the best reputation either. So it's not just limited to, say, private organizations or those who are primarily profit motivated. I see data breach there. That was an interesting one that I wanted to mention that came out of the social license work. It's something that we hadn't seen in the literature before, but it was that some people in our process really wanted to have punishments in place for people who were misusing data. And that was something that we hadn't seen a lot before. And it was kind of one of the more minority views. Not a lot of people said it, but we highlighted it because it was so interesting. Yeah, this is really interesting. Maybe we can go back to the slide. And again, I told you it was trust. It's always about trust. And there's related themes there. You can see like mistrust, misunderstanding, privacy. All of those things are very related. And then another theme I think that came out here today, and also here at the forum was this idea of plain language, health literacy, data literacy. All of those things are sort of intertwined together. We have one more question, and then your work is done. So what do you think that the collectors, holders, and users of health data should do to overcome these barriers? And then we can go back to Slido. I'm not surprised that public engagement is coming up. I think it would be embarrassing if that didn't come up as big as it does at a conference like this. Plain language, training in OCAP, that's ownership, control, access, and possession related to Indigenous data sovereignty, extremely important. I see stewardship of data, that's a big one. Knowledge translation. Ask the public, so related to public engagement. Fewer questions, that's interesting. Simple surveys, I think that's an important one. Yeah, visuals versus text, again, plain language, how do we communicate in a better way? Accountability. Okay, again, I see very similar themes, so we can go back to the slide. Transparency, public engagement, communication, collaboration, knowledge translation, very similar. So it's nice to see that there are some differences, but in general, we all have a pretty good understanding of the issues and then what needs to be done. So what really matters to the public, and I think that's Jannath. So as I said, we were hoping to kind of, based on all the discussions and dialogue we've had with various members of the public, pull out some key themes. So I'll let Jannath talk about that.
Hi, everybody. So to conclude today's session, we're going to highlight the key themes that have come out of the various discussions and public engagement about health data that has happened over this year and even today. So that's the public forum in April this year, the continuous discussions that we have with the PAC, the social license work, and a lot of these themes have also come up in the Slido questions today. And we don't have all the answers, but the questions that have come up through these public engagement sessions are really going to guide our priorities and action items going forward. So the first of these themes is trust, which we have looked at a lot today. We have heard about the inherent mistrust that some communities and groups have in the government, their healthcare practitioners even, and the academia. And this comes from a history of mistreatment. And these are more often than not the systemically marginalized populations. We've also heard about trust in the context of data collection and data usage, and the varying levels of trust that people have when it comes to the different entities that are holding their data. For example, their healthcare practitioners versus the public sector. And the next theme is public benefit. And the importance of public benefit is something that came up during the social license work. And there was consensus that health data should not be used if there is no individual or societal benefit. And if we think about these words a little bit, we'll also find that public benefit does not always mean that the benefit has to be to the entire population. It can be benefit to a certain community or a certain group or an individual, so long as there is some visual benefit. So the question there is then, how do we measure public benefit, and who is the judge of what is public benefit, what is not public benefit? And does the benchmark for public benefit differ when the data is being used by the public versus private sector, for example, or even academic research? And this is, again, because of the various different factors that give rise to mistrust or bad reputations, like we saw earlier in the Slido. So the important question there is, again, like, what are the safeguards that need to be there when there's like different public versus private sector organizations that are using the data, and who should be the judge of what qualifies as public benefit? And on a similar note, we have equitable data collection, which is key for anyone working in a health data space. And here I'll quote Dr. Kim McGrail. She's here. She's the scientific director for HDRN Canada. She said at the public forum earlier this year that raw data is an oxymoron, which implies that there is no such thing as raw data, because how we collect and what we collect is very highly influenced by power dynamics and structures. And health data is very powerful. It has the power to influence and move forward the system, but at the same time, it also has the power to cause a lot of harm, which is why we need to be careful. And that brings us to transparency. The public needs to be informed and involved in the process of using their health data. And transparency cannot be talked about without reiterating the importance of plain language, communication about how and why the public data is being used, for what purpose, and what is coming out of it. And this health literacy, health data literacy, and data literacy in general is very important, because people sometimes don't realize that, for example, the data that they're giving out to their bank may be used for secondary purposes, and what can come out of that and how that can impact them, which is why data literacy is such an important issue, and that cannot come without plain language. And lastly, we have the topic of private sector use of data, which is a little bit more complex than the other themes we've looked at today, because people feel differently about different organizations within the private sector itself, and we need to define what the private sector is. Is it commercial organizations? Is it insurance companies or drug companies? Because a lot of the times when people hear the word private sector, they immediately think of huge companies with large profit margins. But then there are also those private companies that are genuinely committed to public benefit. And oftentimes they're also like supporting the functionality of the private sector. Yeah, I get confused between those two words. But yeah, so they're often also supporting the functionality of the public sector. So we need to be able to differentiate between these public good-driven versus the profit-driven private entities. So and then there's the main question of what additional safeguards should there be when the private sector is handling data. And one of those important safeguards is definitely no access to identifiable data, because at the end of the day, the privacy and confidentiality of members of the public is the utmost priority. But then there can be a lot of additional safeguards as well, as we've seen in the Slido questions and the social license work. And so to sum it up, we have talked about trust, public benefit, equitable data collection, transparency, and private sector use of data, which are the 5 key themes. But then there's so much more that's going on in the background that highlights these 5 key themes. And I'll give it back to Julia, I guess.
Thank you, Jannath. I think that was an excellent summary of the themes that we've heard. And again, there's a lot more to that, and there's a lot of nuances and a lot of things within each of these very broad themes that we're hoping to work on as we go forward at HDRN Canada. But to get us excited about where we are going from here, just a bit of forward thinking about some of the ways that we're going to kind of move these priorities forward. We're, as we speak, going through a priority setting exercise with our Public Advisory Council, which is based on many of the themes that were discussed here today. And we're really in the process of determining where these priorities lie. Do they lie directly with the Public Advisory Council, of course, working closely with the Public Engagement Working Group? Are they priorities more for the network as a whole? Or are they priorities that maybe are out of scope for what HDRN Canada's mandate is, but potentially areas of influence? So that's kind of ongoing as we speak. In terms of other public engagement initiatives, there is a lot going on, but the health data social license work is really expanding, which is exciting. We are in the process of submitting a manuscript that is going to be a bit more of an academic audience, but we do have about 13 co-authors who are members of the public who were part of the original process, who are going to be co-authors on this manuscript, which is exciting. But we are also developing international partnerships. So we've had some interesting conversations with people in Australia who have done similar work on social license, and we're hoping to create some joint work in that area. So keep an eye out for that. And then the Plain Language About Data project, that's something we're hoping to continue to work on in the near future. So we have about 10 minutes left for discussion. That's okay. I wish we had a bit more time, but that's all right. And again, we don't have to talk about these questions, but just something to get you thinking. But you know, if you do identify as a member of the public, I think we all do, patient or community group, what do you think the main issues are? You can talk about some of the things that came up in the questions today. If you are a researcher or a policymaker, a healthcare professional, what do you think the barriers are in involving the public in these types of discussions? Have you ever seen a situation where health data maybe is being used to harm a certain group of population? Or the positive spin on, have you ever seen health data being used in a way that's telling positive stories about a community? Or where do we go from here? We'd love to hear feedback or areas that we should work on. So I'd be happy to hear questions from anyone here, or if we have anything coming online, and there is a mic as well. Yes.
So I'm from the Okanagan in British Columbia. I'm a patient, and I think that a danger is to vilify the public sector, the profit sector, if you will, in terms of what we will offer them. Because in some diseases, it may be that when a surgeon assesses you and says, you know, what the procedure will be, at best you may be getting a well-informed opinion. If there is well-informed artificial intelligence to back that up, and that data may have come from places like these different entities, I think there's great value in that.
Thank you. Yes, and again, that came out in our discussions as well, as we can't just vilify certain organizations or certain types of organizations, whether they be private sector or commercial, because oftentimes there is a benefit there outside of profit, right? And we need to be able to get the benefits out of health data no matter who's using it and how, for sure. Yep. I don't know if there's anything online. I think we had someone here who was...
Yeah.
Ah, hi.
There is a question online.
Cool.
It's on the Slido actually, and it's how can consensus center EDI denied groups? I can ask it again if that didn't make it around the room. Hi everyone. How can consensus center EDI denied groups?
I'm not sure if this is, again, referring to... I wish I knew when the question came in, but...
I think it was earlier when we were having the discussion around the PAC.
Okay, so not, because I was wondering if it was related to how we, like the consensus building in the social license project, because people have had, not questions, but why did you try to do that? Like, why did you try to come to consensus on these certain topics when people have very diverse opinions? And I think the issue was that there was already a lot of work ongoing, and we already knew a lot about what people felt about health research or about data uses. We wanted to kind of better understand if there was what we're calling a center of social license. So were there uses and users of health data that we felt were, or this group felt were within social license that everyone could agree on? Now, with respect to EDI and EDI groups, what we say in the report too is that we engaged with, it was a diverse group of members of the public, but it was 33 people. That is not going to be representative of everyone in Canada or even within a certain community. We did have people who were representing different communities, different systemically marginalized populations, but we by no means think that what we had found is going to be representative of the perspectives of different groups. You know, for example, we had one individual in the process who identified as someone from an Indigenous community. Do we think that this was not an Indigenous-led process? You know, so one of the recommendations in the report was to actually do a specific Indigenous-led exercise similar to this. So I hope that answers the question. Over there is a mic if you.
I don't know if I need it, but okay. So yeah, I guess I could identify as both researcher, policymaker, and patient or community group. And I guess some of the things that I've observed is like that low-hanging fruit around equity or diversity. So I'll use myself as an example. Like, I'm a Status First Nations person from BC. I'm a female. I'm a mother. Whatever. So I'm a really good candidate to sit at tables because I'm a nice gal. And I'm saying that to be a little bit tongue-in-cheek because, you know, I think that there's often a lot of risk and tendency to go to the good contributor who's articulate. Oh, and I'm also a doctor, but I fit in these groups, so I actually am a good candidate within these criteria, and I wouldn't say that I'm a very good person to speak for, you know, our communities as trends that are actually represented in these social issues that we're kind of looking at approaching. And so I see that as a bit of an elephant in the room because we do have folks that are standing in spaces where there might be a little bit more need for humility from both the researcher or the person, you know, asking those questions or asking that person to be in the committee, but also from the person that's identifying in those areas. Have I experienced racism outwardly? No, I haven't. I have white skin. And so, you know, to talk about anti-Indigenous racism really is, you know, requiring me to have a level of allyship or humility in me standing in those spaces. So I do see that as a harm within health research, and I think that intersects with one of the points that might be discussed further here is when we're talking about for-profit or non-profit, sometimes I struggle to see that interest because, you know, when we look at funders like CIHR, there's a huge interest financially from researchers, whether they be associated or affiliated with a nonprofit or not. So, you know, I'm doing social research and it's to contribute to policy, but I'm also getting paid $130,000 to do that research. I'm not sure that, you know, we really have determined what for-profit looks like when folks are buffering their resume over years of social research with those low-hanging fruit representatives on their committee. How is that actually applied in community? So those are some of the things that I'm thinking about in this circumstances, you know, that application and accountability and evaluation that isn't necessarily subscribing to that point that you had around power. And I just see a lot of power in social research still. So just a comment, also maybe an example a little bit, but
so many good points. So we only have 2 minutes left, but a couple things that came up in my mind. One, this idea of the issue I think that a lot of us struggle in terms of patient and public engagement is that the people that we really want to engage with don't have the capacity to come to these tables and talk to us about this, right? And then something else that you had mentioned, you know, you are a First Nations individual, but you have white skin, you may not, like, this idea of visual diversity. So you can't look at a group of people, even on our Public Advisory Council, and say that, oh, they're a diverse group of people, or they're not, because they all have this characteristic and this. So it's this idea of visual diversity. And I know we've all heard the term as well, tokenism, right? So even and I'll take the example of our Public Advisory Council, we may have 2 people who are coming from Indigenous communities, but we don't want to just take a box and say, well, we have that, so we're good to go. We know everything that we need to know about how Indigenous people feel about this. But these are all issues that we're struggling with, like on a daily basis, of how to better engage with all of these different populations that need to be engaged with. And you made a really good point about, like, profit and not necessarily just with the private sector, and how do we define that? And one thing that came up, and I don't even remember where it came up, but was, a motive for doing research is that an academic person, a researcher, can put this on their resume or their CV, right? Is that a good motive for doing this type of research? Is it really a priority for the people who are being affected by it? So that was a good point. It was excellent summary. It looks like we have 20 seconds left. I don't know if anyone has a really quick thing to say or... Yes.
I think the importance is that we have people with lived experience. And more than anything else, we can tick off boxes, but if they don't have the lived experience, there's no point in them being on the committee. And I know that one earlier, they mentioned WOW, women, white women. What was the acronym? Wow. White
Yeah.
older women. Okay, yeah, speaking in defense of older women, I have to say that they are the ones that have the most experience in the healthcare system generally, because they look after their children, they look after their grandchildren, they look after their spouse, and I mean, they have so much experience in the healthcare system, not just for themselves. So I really object to the fact that we are against having white older women on their committees. Sorry.
Yeah, these are all valuable points, and I think at the end of the day, we all, as you said, have that lived experience. We all bring something very different, no matter what we look like, no matter what demographic characteristics we're bringing. We are all bringing a very different, unique perspective. So trying to fit us into different boxes, right? And as you said, like, we identify as many different things, right? We're not just one. We're not just a First Nations individual. We're not just a mother. We all come with a lot of different experiences. So just keeping that in mind. And I know it's very complex, and again, we don't have the answers, but it's really nice to be in a room and to have those discussions with you all. So we're a minute over time. Thank you so much for your valuable contributions, and thanks for joining us today.